Hi everybody, it is Ajanette and I am here to do your lecture presentation on eating disorders. So eating disorders are a very interesting psychological disorder category. Many people don't realize how dangerous they are. And although fortunately they're not as common, their relapse rates are really high. And they also have one of the highest mortality rates of any psychological disorder. So let's learn a little bit about them. When we talk about eating disorders, there are 6 eating disorders outlined in the DSM: pica, rumination, avoidant restrictive food intake disorder, anorexia, bulimia nervosa, and binge eating disorder. We're going to focus on the last 3. Those are the ones that are more commonly known. And you should also know that these disorders are all mutually exclusive. In other words, if you're diagnosed with one, you can't be diagnosed with another. It's one or the other. But the only one that can be diagnosed with other eating disorders is pica. And pica is eating odd things. So some people might eat hair. Some people might eat, foreign objects or substances. But it can be diagnosed with the other disorders, but you cannot be diagnosed with like anorexia and bulimia at the same time. And interestingly enough, they do have some similar symptomology that we'll talk about. So eating disorders are serious conditions, and they're very hard to treat because, it's not like let's say that we have like a substance abuse disorder where, we're alcoholics, okay? Well, we can cut alcohol out of our lives. We can't cut food out of our lives, right? So it requires a much more specialized approach and discipline because we have to learn how to have healthy eating habits in our lives. Eating disorders are far more common in westernized societies. Our learning activities is going to have you explore that and focus on that. Why? What is it that you see or experience in westernized society that might make us more susceptible and vulnerable? So I want you to seek out examples in the media. I want you to seek out cultures, values, traditions, practices. What separates us from other cultures? What is it that's unique about us that makes us more vulnerable? What's really interesting is when they've introduced westernized media in underdeveloped or in developing countries and nations, they have increases in the rates of eating disorders. So I want you to think about that and build upon that concept. So do your own exploration and research, and then bring examples forward for discussion in our learning activity this week. One of the reasons eating disorders are so complicated is because there's a number of factors at play. There's biology and genetics, there's our psychology, our thought processes, our personalities, and there's sociocultural factors. There's our westernized culture views, there's our family views. So all of those things work together to create our mindsets and our behaviors that might contribute to eating disorders. So it's a combination of factors. Anorexia is probably one of the more commonly known eating disorders, and this is where there's a restriction of food. Now, anorexia can have both binging and purging that's associated with bulimia, but it can also have food restriction, hyper-restriction. So it can have characteristics of what we would typically think of a bulimia. The defining characteristic that lets you know whether it's anorexia nervosa or whether it fits that criteria is really the body mass or the weight. When they hit 20% below their average body weight, then that typically means they've crossed over into the anorexia nervosa. So they are underweight. Unfortunately, though, they have this altered perception of themselves and they have a poor body image. So even when they're looking at themselves at a normal weight or even at a below average weight, what they're seeing themselves is an average or above average weight. So they see themselves as being fat almost no matter how skinny they get. And it's this very intense obsessive fear that it's a real fear that they're afraid of getting fat, of gaining weight, and it really terrifies them. We see it more often in women. Men are vulnerable to anorexia. We see men impacted by bulimia a little bit more commonly than anorexia, but we do want to make sure that we're not ignoring symptoms in men as well. So sadly, with this eating disorder as well as bulimia, it often starts with dieting, right? When we start to restrict or maybe eliminate, we're eliminating carbs or eliminating sugars and, chocolate, cakes, those types of things. And that can become obsessive and it can progress over time and develop into an eating disorder. Our teens are very vulnerable. We even find young girls now more likely to develop eating disorders than they were in the past. So even as young as age 8, struggling with symptoms of anorexia. So watch out for the symptoms and the warning signs. I want you to know that as you're going through this lecture yourself, a lot of the images that I put in here are linked to resources. So feel free to click on those. You may actually have to have it in presentation mode, but click on those because these images, many of them take you to other helpful websites that have not just educational information, but resources. But some of the symptoms you want to watch out for is dramatic weight loss when they're underweight, but their perception of themselves may contrast with that. They may see themselves as fat. They may make comments about feeling fat, looking fat, but they make comments that are derogatory about their body. But yet they're obsessed with food. They're obsessed with weight. They want to know how many calories and everything before they eat it. And they're obsessively counting those calories. They might be restricting what food they're going to eat, how much they're going to eat, when they're going to eat. I have one of my students who suffered from anorexia. She'd allow herself one piece of lettuce, and she actually had like a diagram of how big the piece of lettuce could be. It had to be smaller than her diagram. And, in talking with her, I'm like, how do you get your protein? How do you get your other vitamins? And so it's a process to try to introduce a more balanced diet. Sometimes they might avoid eating in front of people. They might make excuses on why they can't have dinner with you, why they can't have lunch, or they might show up a little bit late. Oh, I already ate, that kind of thing. But because of that malnourishment from restricting their food intake, they have physical symptoms as well. So dizziness, some of them might faint. That might actually trigger medical intervention. They have a hard time concentrating. Their body's not getting the energy that it needs. The brain's not getting the fuel that it needs. They feel cold. Often it can lead to anemia. They might have difficulty sleeping. They lose hair. Their nails might be brittle as well. And they overall get muscle weakness. And sadly, we're talking about the psychological aspect, but there's major physical ailments associated with anorexia. One of those is the body eats away at the muscle in order to generate the energy that it needs to function, and it can even eat away at your heart muscle. And so anorexia long-term can cause heart damage, and often that can be one of the underlying health issues that could lead to death. So it's a serious condition that needs addressed. Now, bulimia is a little bit different. Bulimia has some things in common with anorexia. As I mentioned, bulimia often is associated with binge eating, so binging and purging. So they might have periods, where they're eating a lot of food, as we're seeing in the first image, and then they do some sort of purge or compensatory behavior to eliminate those calories that they just took in. And that might be vomiting, self-induced vomiting. It can be excessive exercise. It can be laxatives. So there's different types of compensatory behaviors we'll talk about. But interestingly enough, because they are taking in some calories, often bulimia is a normal weight. But like anorexia, they also have poor body image. They also are afraid of getting fat. And they also are terrified of gaining too much weight, of gaining weight in general. What we see, because vomiting is the most common compensatory behavior, this bottom image is showing you some of the damage to the teeth and the roof of the mouth, because those acids aren't meant to be in your mouth, right? So dentists are often the ones that can see signs of bulimia, and diagnose that. So this occurs a little bit later, late adolescence and early adulthood. Often think about like puberty. We gain weight naturally with puberty. And so that might kind of trigger things as well. It again might be prompted by dietary behavior. And so even in the dieting, they might have periods where they binge in the diet. And, so they often stay at normal levels of weight, and then they engage in that compensatory behavior when they need to drop below. But it's a combination of binging and purging, or binging and compensatory behaviors. The binging are small periods of time. It's not excessive, but they often eat larger amounts of food than average. They take in more calories than average. And when they're in that binging mode, they often describe it as something outside of their control. They feel shame, embarrassment, even disgust with themselves. So it has huge psychological implications, but they can't control themselves. And this is why a lot of people associate, or they think that eating disorders are a type of OCD, particularly bulimia nervosa, obsessive compulsive, where they have those obsessive thoughts that they can't control, and the compulsions or the behaviors that help to relieve the anxiety producing thoughts. And so this binging and purging kind of is similar to that OCD cycle. Here's some of the more common compensatory behaviors. So just trying to rid themselves of calorie. They might also use stimulants, sometimes like cocaine or meth even. But in order to meet the diagnostic criteria, they're binging once a week and purging for at least a 3-month period. So things that you want to know about binge eating disorder things you want to know, about binge eating disorder is that it's different than bulimia. So with bulimia, we have the binging and the purging. With binge eating disorder, it's just binging. There's no purging. And you don't have any of the compensatory behaviors. You don't have the, excessive exercise or the vomiting or the laxatives. But they do have that same shame and guilt associated with the binging. They do describe it as being outside of their control. And because they're taking in short periods of time excessive amounts of calories, they do have higher weight levels and risks of obesity. Because they might be embarrassed about that binging process and the uncontrolled nature of it. They may not want to eat in public. They might do it very secretively. And they hide evidence, so they clean up their wrappers, hide their plates. So those are indications when you have someone that's kind of in the closet eating high volumes of food. That's concerning. So this actually is different than the other eating disorders we've talked about, in that middle adulthood becomes the age period where it's a risk factor. And we do have higher rates of males represented with this eating disorder. And it's phasic rather than persistent. In other words, people go through phases. It's not something chronic that's persistent, a persistent part of their lives, but they might go through phases. So let's talk a little bit about the epidemiology, so the prevalence and, what are the other disorders that occur with it. So as I mentioned, as you can see by these rates, they're not really common disorders. However, they are in fact dangerous. And because they involve so many medical risks in addition to the psychological damage, they really need to be treated by professionals. This is not something you can address on your own. It's not something you as a loved one can do to help fix them. They really need to work with medical professionals and psychological professionals in order to come up with healthy strategies for themselves. We do see that although it's not common in men, we know that we have about a 10-to-1 ratio with 10 women, 1 man for every 10 women that have anorexia and bulimia. But you see that with men, though, with binge eating disorder, though, we do have higher rates of men. In terms of comorbidity, all of them are often experience depression. Whether the depression is a contributing factor or a resulting factor, we don't know, but it's not uncommon that they're co-occurring with depression. Anxiety, particularly for bulimia, social anxiety is often prevalent. With anorexia, OCD, particularly for those that are restrictive, they often have OCD tendencies, or they can have the obsessive compulsive disorder diagnosis as well. Alcohol and substance use are very common with the binging and purging. In fact, we see bulimia and alcohol and substance abuse disorder commonly co-occurring and being diagnosed together. And as I mentioned, they have a high rate of suicide. The mortality rates for this are deeply concerning in our field. With bulimia, personality disorders are often a risk factor, particularly borderline personality disorder. And so it's really challenging because personality disorders in general are really hard to treat. And so that makes it a little bit more resistant to help and recognizing, that they might have challenges that need to be worked on. And so they might be in denial about that. And that's problematic because it hinders treatment. And then binge eating disorders, a fairly new diagnosis category. It started in 2013. So there's still research being done. We don't have the full understanding of the prevalence rates. However, we see that diagnoses tend to occur similar to that of other eating disorders. We do know that multiple factors contribute to eating disorders. There does seem to be some sort of genetic predisposition, but we haven't identified a specific gene. Environmental factors are critical, especially family. And so we'll talk a little bit about family factors in treatment. And then again, culture, westernized cultures that emphasize thinness, that have beauty ideals that might be unrealistic and centered around thin bodies. Eurocentric cultures tend to be those that have higher rates of eating disorders. So think about, a lot of even within the U.S., like Black culture, right? They tend to have a greater appreciation for various body sizes, and thick women can be beautiful too. And so it's not always about that unattainable thin standard. Cognitive factors play a role, and this is why cognitive behavioral therapy is so effective with eating disorders, or more effective, I should say, because it addresses the underlying thought processes and the maladaptive thinking. But as I mentioned, many professionals believe that this is some sort of variation of obsessive compulsive disorder. In fact, at one time, it was categorized as, a related OCD disorder, where they have those obsessions mentally about their weight and food and their body shape, and they have distorted views of their body shape. And then the compulsion is the food either restriction, or the compensatory behavior. So the obsession is the thought process, and the compulsion is the behavior. So very, very related to OCD. And those distorted thought processes have to be addressed in therapy. They have to be replaced with healthy, positive mindsets, positive thought processes and strategies. Additionally, they often overestimate their weight. They look at themselves, what they see is not what you and I might see from the outside. They tend to be impulsive as well, and that impulsiveness makes it difficult for them to control those urges, to resist those urges. And then the guilt and shame and the low self-esteem that emerges, or that might be a contributing factor, is problematic as well. So that's why cognitive behavioral therapy is in fact one of the preferred approaches to treating eating disorders. In terms of biology, as I mentioned, we haven't identified a specific genes, but again, we've done family studies, we've done gene studies. We know that you're 6 times greater, or you're 6 times at greater risk if you have a relative with a disorder. And for anorexia, identical twins have a 70% concordance rate and fraternal twins a 20%, meaning 70% of the time one twin is diagnosed, the other twin as well. Bulimia, much lower, 23% for identical twins and 9% for fraternal. There might also be your endocrine system and your nervous system are the two systems that kind of control our brain and our body. And so there's disruptions there. The hypothalamus in particular, which is, it plays a role in both our brain. It's a structure within our brain, but it also kind of activates the pituitary gland, which is your master gland controlling your endocrine system. And the hypothalamus is critical to our food consumption. The lateral hypothalamus is associated with hunger. So when it stimulates you to eat, and then the ventromedial hypothalamus is associated with satiation. So damage, disruption, or lack of healthy functioning in either of those areas either might make you hungry all the time, might make you not hungry, might make you feel full when you're not full or when you haven't ingested enough, and might make you never feel full. So those are the biological areas where we want to focus on doing more research, looking at how we can treat those areas for eating disorders. Other factors are personality. Perfectionism is a problem. I tell my personal growth students all the time, so I'm going to tell you. Perfectionism undermines our mental health and well-being. It adds stress to us. It adds unrealistic psychological expectations and pressures upon us individually, and it often does on those around us. So it's something that spills over to our relationships. So we want to be careful. It's problematic with eating disorders because we need our bodies to be perfect. And we just can't have perfect bodies. As somebody who's recently been diagnosed with breast cancer, and I thought, I'm now facing losing my breasts. I'm now facing losing my hair. And I'm like, shit, I spent all my healthy years criticizing my beautiful breasts, my beautiful body, and what an appreciation and love I have for it now in these moments. So individuals who impose those standards on us, they can be instilling this perfectionist mindset that's dangerous for us. So that's something that has to be addressed in therapy. Self-esteem is also an issue. We call it a moderator because it actually can influence both us developing this disorder as well as us maintaining this disorder. So it actually can, if we have low self-esteem or high self-esteem, it might be problematic, right? And low self-esteem makes us more vulnerable. So there is a transdiagnostic model involved where because of that low self-esteem, right, we're overly critical of ourselves. We're hypercritical of ourselves. And so we might find comfort in eating, or we might avoid eating altogether. But either way, it opens us up for an eating disorder. So it's a problem. And again, because it's so complicated, it involves a proper response. So you have to have medical intervention, psychological intervention, and often part of the medical team is a dietitian to make sure that we're introducing healthy food at the right amounts for your body. So with treating anorexia, what we want to do is first and foremost address the malnourishment, again, because of the major physical health issues that arise. Often that's done if it's been going on for some time, and depending upon how low the weight is, they may need to be hospitalized. They need to be in an inpatient facility. You cannot just force someone who has not been eating to start eating. That can kill them, actually. So you need to introduce food in the right amount, the right types of food. And then you also need to couple that with therapies. And the goal of the therapy is to try to help address that maladaptive thinking and to replace their poor eating habits and their often, delusional thought processes associated with that eating, with healthy eating habits. So build on that relationship with them and food. Cognitive behavioral therapy and family-based therapy are the two approaches that you see. In cognitive behavioral therapy, or CBT, there are behavioral strategies. So they might have to log how much food they eat, when they eat, what type of food. They also might have to record how they're feeling about that food, what's happening in the environment. Is there something that has happened in the day that might be triggering it, or that might be related. That's particularly important for bulimia, which we'll talk about. But then what they do is that journal now becomes a tool in therapy, and they can address that negative image, that negative body image, that self-esteem issue, the fears that they have surrounding weight and getting fat. And the therapist can help reframe those things. Family-based therapy is especially important for children. And think about this, it doesn't do any good to treat a child or an adolescent teen and then just put them right back in the family dynamic that contributed to the eating disorder, right? So family-based therapy isn't just taking care of the child, it's also educating the parent. It's teaching the parent how to be part of the solution and how to avoid some of the problems that may have contributed. And so this is about putting on healthy weight. So it's been very successful in helping to restore weight and maintain a healthy weight over time. It's been very helpful in avoiding hospitalization, so it can be a more cost-effective option. But it is a long-term therapy option. And what you want to do is that families are often enmeshed. That's one of the characteristics that contributes to unhealthy family dynamics with eating disorders. And so you want to separate out that enmeshment. You want to pull the child away and let them separate and understand who they are individually, what they feel individually, independent of their family, right? And parents can be an active part of helping to, empower the child and work on weight restoration. But ultimately, the client needs to gain a sense of control over their food intake, over their own lives. And so you have to foster that autonomy. You have to encourage them, because sometimes anorexia, eating disorders in general, the only sense of control they have is over their food. And so you want to give them control over other areas of their lives, and most definitely in their treatment. In bulimia, cognitive behavioral therapy, same. Food journals triggers become crucial, right? Because if there's something that makes them particularly emotionally upset, that sparks that obsession and that desire to binge, then that's problematic, right? And so we want to start identifying what those triggers are, identifying those high stress moments, identifying those unhealthy eating habits that might be triggering binge sessions, and we want to replace those thoughts and those behaviors with healthy alternatives. We also can use exposure and response prevention. So when you identify triggers, you can intentionally expose them to emotional triggers, and then they are not allowed to engage in the behaviors, right? And so what you're trying to do is teach them alternatives. You're trying to teach them, okay, when I'm feeling this way and I'm triggered, I can start to journal. I can start to do meditation. And the therapist will work with them to identify strategies they can actively utilize to counter those urges. And then again, this is the cognitive part. You want to address that maladaptive thinking, and you want to reframe it and replace those negative thoughts with healthy, appropriate thoughts, right? Realistic thinking. Interpersonal psychotherapy when you're talking about interpersonal, you're focusing on relationship dynamics. So there are interpersonal challenges that might be contributing to these eating disorders. They might have challenges in their relationships. They might feel social isolation. Consequently, they might feel, they might have low self-esteem, and they might have poor relationships. And so with this type of therapy, you want to educate them. You want to build social skills. You want to teach them not only about the disorder, but the treatment, and about healthy interpersonal skills that they can use to build healthy relationships with others. So you're going to identify the problems with the patient, and then you're going to go through problem solving with the client, where they're going to identify what is contributing to these dynamics, and what do you think would be good strategies to address them? How do you think you have tried to address them in the past, and how has that worked? What are some more effective strategies? So that's a really key thing, is the client gets to be involved in the problem solving. You don't solve the problems for them, because remember, it goes back to control. You want to put them in control of their health moving forward, and give them the opportunity to implement changes in their mindsets and their lives that are going to be healthy. So you want to, once you have those plans in place, now you can space out the treatment, give them time to implement those changes and plans that you put in place together, and they can monitor their progress. You can also talk in advance about, okay, what if I'm tempted? How can I prevent that relapse? And you can put backup plans in place with them, and then give them that opportunity to practice cultivating those skills and to build progress over time. So for binge eating disorder, similar to bulimia, cognitive behavioral therapy, often we see antidepressant meds, because remember, there's comorbidity, right? So they might be getting medication for the other disorders like depression or anxiety. And so it's not uncommon with binge eating that they do suffer from depression. So you'll treat them with antidepressants. That has a great effect on the depression symptoms, but it doesn't help with the weight loss per se. There's also the dialectical behavioral therapy, where they're working on the binging, and it does show some effectiveness with reducing the binging, but again, they're not able to reduce the weight. So they still struggle with weight issues and obesity. So in terms of outcomes, as I mentioned, outcomes, they do have high rates of relapse. And so it's not uncommon with anorexia, bulimia, and binge eating that it's something that they're going to relapse and deal with for the rest of their life. So they need ongoing love and support. The earlier you catch it, the better. If you can intervene at a young age before they really have had a long time to depend on these behaviors and develop trust in these behaviors, then the better off it is. So the shorter the history, the shorter time period they've been dealing with the symptoms, and the earlier age, the better the treatment outcomes. So unfortunately, if they've, this has been built into their lifestyle and their mindsets for some time, it's harder to treat. And again, mortality rates are about 10% for anorexia. And that could be because of some of the underlying medical conditions that I mentioned, but also they're at a higher risk of suicide. So that's really, really important to address. And then bulimia, we don't have key predictors, like, we can't really say what is most effective at helping or determining that they're going to have a successful outcome. So that's a problem, because it's hard for us to figure out, what we should keep doing that's working and what we should stop doing that's not. It really varies from person to person to person. Again, if they've had childhood obesity, low self-esteem, or personality disorders, it can hinder a successful outcome. And then we're still working on research with binge eating disorder, but we are showing that remission and relapse rates are significantly higher, even more so than anorexia and bulimia. So I want to close today with some resources. So if you have ever struggled with eating disorders and this particular lecture is triggering to you, there's resources out there for you. If you already have a therapist, I would encourage you to reach out to your therapist. Talk about it, even if it hasn't been triggering. Just talk to them anyway. Talk about what you've learned. If you know somebody that might have some of these symptoms, I would say reach out for help. Call one of the crisis lines. Call NAMI. Call the NEDA, the National Eating Disorder Association. Get some guidance. What's the best way that you can address them, that you can talk about the issue, that you can show support and love. And it never hurts to tell your friend or family member, I love you and I'm concerned about you. And whatever you need for me to help and support you, I'm here. And I'm sharing that with all of you. If there's anything I can do to help and support you. I'm not a therapist, and if I were, it would be inappropriate to offer you therapy as your teacher, right? But I can be a cheerleader. I can be an empathetic and kind and compassionate ear. So I want you to know you're not alone, and we do have counseling here at MSJC. So take advantage of the health services here that are part of your regular tuition, and then reach out for help. And the first step is always educating yourself. So here's some links to educate yourself. Again, many of the images throughout the PowerPoint or throughout the presentation also have links as well. I wish you the best. Take care of you and know that you are beautiful just the way you are. Every little imperfect inch of you is beautiful just the way it is. Bye, everyone.